Okay, good evening, everyone. Myself, Dr. Santosh H. Agrawal, Honorary President of Maharashtra Ophthalmological Society. I warmly welcome you all to this distinguished BOA MOS Journal Club Season 3. At the outset, I congratulate Dr. Vaishal Kenia and his team for successfully running this activity of Journal Club meeting for last 3 years. Today we have an unique topic, very important topic pertaining to herpes simplex and varicella zoster anterior uveitis. I extend my best wishes to the presenter, Dr. Priyanka. I hope today's discussion would enlighten us about the insight of this topic and the latest paradigm to deal with this disease. I thank all the panelists, especially Dr. Sumita Karandikar ma'am, Dr. Somshila Murthy, Dr. Aniruddha Agrawal, who is an international speaker for today's discussion, for sparing their valuable time for this journal club. I also thank Dr. Neeraj, Dr. Zain for moderating this session. Journal club meeting always help us to update our knowledge in regards to latest trends in ophthalmology. It is not only helpful to our PGs but also our practitioners as well. Eventually, it improves our approach to our patients. I once again thank Dr. Vaishal Kenia and his whole Journal Club team for such a wonderful activity. MOS always strive for academic excellence of our members. I extend my warm wishes for this activity. Thanks for giving me the opportunity to talk in front of you. Thank you so much. Over
Thank
to
you for
Dr.
those.
Vaishal.
Yeah, thank you for those kind words, sir. Now I would ask the President BOA, Dr. Nitin Balkrishnan, to say a few words.
Good evening, everyone. On behalf of the Bombay Ophthalmologists Association, I welcome you all to this Journal Club meeting. Right at the onset, kudos to Dr. Vaishal Kenia, Dr. Parul Deshpande for having continued this particular program of Journal Club, which, like Dr. Santosh Agarwal mentioned, is a very important thing, especially in PG teaching, and also for people who are in practice, because many of the topics which are being discussed are practical topics of very much importance in our day-to-day practice. And it's a very important thing to remember that journal clubs are something which give us a lot of information, especially for busy practitioners who hardly get time to go through individual journals. These are the synopsis, the best of the best, which is being presented over here. So without wasting much time, I would like to invite Dr. Aniruddha Agarwal, Dr. Somashila Murthy, Dr. Sumita Karandikar, and thank you all for having spared your time on a busy day from your practice. And welcome to everyone. And I would now hand over the podium to Dr. Vaishal and his team.
Thank you, everyone. Once again, I brought you another episode of the Journal Club meeting, Season 3. Today, we have very distinguished infectious uveitis specialist, and they are going to discuss this topic in depth and dissect each and every point on this landmark article on uveitis. And I have this opportunity today to introduce Dr. Somashila Murthy, who is a very known and a renowned name, not only nationally but internationally. She has been a faculty for 22 years at LV Prasad and serving as the head of cornea and uvea at LV Prasad from 2013 to 2023. Today, she is the founding medical director at Shantilal Sanghvi Eye Institute at Mumbai, Vadala. And she has been very research and academically uh, intense. She has got 300 plus publications in her name, and she is one uveitis cornea uveitis specialist whom I know at very personal level, and she's very passionate about her work, and she's very academically oriented and loves teaching this thing. So we would really love to listen to her today. So without further ado, I would ask Dr. Zain Khatib to introduce our international faculty today. Dr. Zain.
Yes, sir. Thank you. So, it is my great honor to introduce Dr. Aniruddha Agarwal, sir, who's currently working as an associate staff physician at the Cleveland Clinic, Abu Dhabi. So, Aniruddha, sir, actually was my senior in KEM 3 to 4 years when I was in MBBS. But I think in ophthalmology, he's gone few decades my senior, the amount of feats he has achieved. So, we are really honored to have him here. He has previously worked as an assistant professor in PGI, from where he completed his long-term fellowship in Vitro-Retina. He's also completed his clinical research fellowship at Nebraska, USA. And he has received the Kataria Memorial Gold Medal from the Prime Minister of India in 2014. And he's authored more than 270 publications and more than 48 book chapters. Basically, right now, he's considered as one of the world authorities in the field of ocular imaging, uveitis, and retinal diseases. So, I welcome you, Dr. Aniruddha, sir, to this journal club of MOS and BOA.
Thank you so much.
I request Dr. Parul ma'am. Parul ma'am, you are on mute. You can introduce us.
Yes, I would like to invite our speaker for today, Dr. Priyanka Menon, who is the junior resident from DY Medical College, Navi Mumbai. And she will be talking about Titan study, which basically discusses the current practice patterns for herpetic anterior uveitis. Now, this session will be co-moderated by Dr. Zain Khatib, Dr. Neeraj, and Dr. Sumita Karandikar, who is the HOD of the ophthalmic department from DY Patil Medical College, Navi Mumbai. Now, I would also like to thank Dr. Sen Gupta, sir, who's also joined here. He would be discussing about the statistical aspect of the study. So with this, can we request Dr. Priyanka Menon to share her slides and presentations? Priyanka? Yeah.
Yes. Is my screen visible now?
Yes, it's visible. Yeah.
Good evening to one and all present here. I would like to take a moment to thank everyone present here and giving me this opportunity, especially MOS and BOA and all the respected panelists and my guide, Dr. Sumita ma'am. My topic for today, I'm Dr. Priyanka Menon, Junior Resident, DY Patil Hospital, Navi Mumbai. The title of the article today is The Infectious Uveitis Treatment Algorithm Network, Titan Report 1, Global Current Practice Patterns for the Management of Herpes Simplex Virus and Varicella Zoster Virus Anterior Uveitis. This was published in the Royal College of Ophthalmologists Journal. Coming to the introduction, anterior uveitis is basically most commonly associated as a viral contribution in majority of the cases. Herpetic anterior uveitis contributes a significant proportion, which makes up to around 5 to 10% of the cases, and a large proportion of these patients are above 60 years of age. Epidemiologically, herpetic and varicella are both most important causes of infectious uveitis globally, not just India. The aim of the article is to present the current expert practice patterns and to formulate a consensus for the management of the herpes and the varicella anterior uveitis by uveitis specialists worldwide. The clinical features are as follows. Both herpetic and varicella anterior uveitis features include diffuse, fine stellate dendritiform or granulomatous keratic precipitates. These patients usually come with raised intraocular pressure, iris atrophy, and these are usually more commonly seen in herpetic anterior uveitis. Clinically, it is quite challenging to differentiate between herpetic and varicella anterior uveitis. The diagnostic challenges are as follows. Obtaining aqueous samples for the PCR testing is important, but it may not be feasible in all possible settings. Varying diagnostic techniques and expertise among the uveitis experts can lead to differing opinions on diagnosis. Methods used in the study were as follows. This study was basically conducted by a 2-round online modified Delphi survey method. This group, Titan Network Group, comprised of 24 uveitis specialists globally and 3 fellowship-trained uveitis experts. There were 100 uveitis experts, including the core committee. They were selected based on their expertise and recognition in the field. They used the currently available evidence, which was Supplementary File 1, which was provided and graded using the Oxford Center for Evidence-Based Medicine Levels of Evidence criteria. And all the participant identities were masked. They seek ethics approval from the Postgraduate Institute of Medical Education and Research in North India, and the study conducted was according to the principles of the Declaration of Helsinki. The survey that happened was as follows. This study basically implemented a modified Delphi technique, and they conducted the study in 2 rounds. The first round included 21 questions, which were across the domains of diagnosis, treatment, follow-up, and also had open-ended spaces for expert inputs. The responses were then recorded using multiple choice questions and answers and a Likert scale. The responses from the first round were then analyzed to create questions for the second round. Then there were 12 questions which were refined for the second round based on the statistical feedback from the first round. The data analysis was as follows. This study analyzed the most frequent recorded responses and used median scores and IQR, which is interquartile range for agreement of the quantification. There was thematic analysis, which was conducted for open-ended questions, and a consensus was reached at more than or equal to 75% agreement or an IQR of less than or equal to 1.4%. The statistical analysis was carried out using IBM SPSS Statistics version 27. The result, right-hand side, this table is given in the article, which basically shows the regional distribution of the experts who participated in the study. The interpretation is as follows. Asia shows the highest number of experts and Africa the least. The participants had an average of 21.7 plus or minus 8.3 years of clinical experience. The response rate, 76% in the first round and 68% in the second round. Coming to the diagnosis and the initial investigation, the specific indicators of the herpetic anterior uveitis included unilaterality, increase in intraocular pressure, decreased corneal sensation, and sectoral iris atrophy. Sectoral iris atrophy was considered as the most important and helpful sign in diagnosing the herpetic uveitis. And this was agreed by around 76%. The aqueous tap was sometimes performed by 36.4% of experts when there was viral uveitis suspected, and presence of classical skin lesions reduced the frequency of the aqueous taps conducted, and that documented to the following statistics. The multiplex qualitative PCR was a preferred choice for the aqueous tap testing, which was selected by 73% of experts, and the 37% experts said they had lack of access to this test, and 35% considered it useless. Goldman-Whitmer coefficient GWC testing was uncommon due to lack of availability. Serological tests were very rarely performed, and these are the statistics given. This is a table from the article given. This is the guideline for the treatment consensus that has been achieved. I would like to enumerate few important points. There was a consensus on starting both antiviral and anti-inflammatory treatment for both herpetic and varicella anterior uveitis without any confirmatory testing. There was an agreement made on the clinical follow-up without repeating any PCR, relying on the clinical appearance for the treatment decisions. The initial treatment was to choose a systemic antiviral therapy without any topical antiviral for both types of uveitis. A consensus was developed against administering any topical corticosteroid without the cover of an antiviral. The duration of the treatment depended on the resolution of the clinical signs of inflammation and IOP normalization. However, the resolution of corneal edema as a treatment endpoint was less favored. Prednisolone acetate 1% was the chosen primary topical corticosteroid. The dosage and the duration were discussed later. The consensus was developed on gradual tapering of the corticosteroid and until no signs of inflammatory activity were seen up to 12 months. Oral valacyclovir was considered as the first-line systemic antiviral treatment for both HSV and varicella, although there was no consensus achieved. Experts preferred using beta blocker topically as a selected IOP lowering agent. This is a flowchart given in the article which shows the approach to a first episode of a clinically suspected viral anterior uveitis. It says that once you see a clinical picture of unilaterality, increased intraocular pressure, decreased corneal sensation, and sectoral iris atrophy, your clinical suspicion should contribute to a viral uveitis. Depending upon whether you see skin lesions or present or not, you may or may not think of a PCR, again, depending upon the conditions where you are practicing. And then your treatment guideline goes as follows. You have to start the patient on a systemic antiviral treatment, which is most favored as an oral valacyclovir. Topical steroid, prednisolone acetate under the cover of a topical antiviral is given. And this is continued up to no inflammatory activity seen. The treatment endpoint is not anything else but the resolution of inflammatory activity, which is seen as no keratic precipitates, cells, flares, and normalization of intraocular pressure. Discussion. What was already known to us was that herpes simplex and varicella zoster viruses are the most common pathogens causing anterior uveitis as a viral cause. And we also knew that there was no firm guideline for the management of the same. What this paper adds to us is that they have developed a consensus, depending upon the Delphi survey, to develop a treatment guideline to deal with herpetic and varicella viruses. For diagnosis, consensus was achieved as per the survey. They said that clinical signs are sufficient without any PCR. A PCR is valuable only when judging between the viral versus non-viral was difficult clinically. PCR testing had high positivity rate in patients with anterior uveitis. A 12-year study in South Korea showed that aqueous tap PCR is suspected in cases of anterior uveitis, and they had low sensitivity, around 0.43%. The GWC, which is the Goldman-Whitwer coefficient, was more accessible but was very costly, and the availability was very limited. A study in Thailand demonstrated that the examination potential of the GWC in diagnosing unexplained acute uveitis was very high. The positivity rate was around 75%. Iris atrophy is typically associated with herpetic uveitis, but not all GWC HSV positive patients in the study exhibited this feature. It was not essential when the clinical picture was clear. However, in patients in whom the clinical scenario was not very clear, a GWC was recommended. Valacyclovir is considered as more efficacious drug than an acyclovir. This was in contrast with the HEDS study, which is the herpetic eye disease study, which was a clinical trial conducted which only utilized acyclovir. Duration of the treatment and determining appropriate endpoints in HSV and varicella are still debatable. A minimum of 4 weeks of a suppressive treatment is recommended. Perioperative therapy recommendation included topical steroid use and oral antiviral therapy for a specified time duration, but no consensus have been achieved so far. The limitations of study are as follows. There was a lack of quantification of annual caseload to the uveitis experts, difficulty in obtaining an even distribution of participants in each region. There was limited representation from Africa. There was exclusion of expertise from the general ophthalmologists who also had significant knowledge on the topic. There was a possible bias introduced by giving a clinical scenario in Delphi survey. Influence of the geographic accessibility and cost on the selection of ancillary testing like PCR and GWC was seen. Coming to the MARI part, methods, the study hypothesis is well defined, the period was well defined, the design used was modified Delphi survey. It included inquiries on the treatment strategies, diagnostic techniques, and patient management. Assessment was appropriate. It assigned healthcare professionals, which were 24 uveitis experts and 3 fellowship trained professionals. There was mandatory participation in the survey which was required to share the insights into the clinical practice. The results were accurate and precise. It was conducted as an assessment of the survey responses to analyze data for common practices. It identified prevalent treatment strategies and diagnostic methods for both herpes and varicella anterior uveitis. The results were as follows. Response rate was 76% in the first round, 68% in the second round. Consensus was reached at more than or equal 75% agreement, or IQR of less than or equal to 1.4. The statistical analysis was carried out by using an IBM SPSS Statistics version 27. It provided valuable insights into the global practice. Interpretation of the results in context of current guidelines and recommendations were generated. Implications of the findings for clinical practice and future research have been provided. And extrapolation. Basically, the study attempted to apply the survey findings to a broader context of uveitis management. It proposed recommendations for standardizing the treatment protocols and improving diagnostic accuracy. It aimed to enhance patient outcomes globally based on the insights derived from the survey. These are the references mentioned.
Thank you, Priyanka, for presenting this article in a very concise and precise manner. I would like to request our panelists, Dr. Somshila and Dr. Anirudh, to give their valuable opinion on this article.
Very good evening. Anirudh, can I go first?
Yes, ma'am, absolutely.
Okay, thank you. First of all, good evening to everyone, and thank you very much, Dr. Santosh, Dr. Nitin, for welcoming us and for including me in this webinar. And of course, thanks to Vaishal, and I also see my friend Parul. So all of us go a long way. I won't say how long, Vaishal, otherwise they'll come to know how old you are. But just enough to say that Vaishal and I were next to next roll numbers during all of MBBS. So we go along. And thanks, Priyanka. I think you did an excellent job of presenting this journal article. As Dr. Sumita said, that it is very concise. Just one thing, that the journal it's published in is I. And Royal College, I think, is the affiliation of the authors. So the publication was an I journal. So coming to directly into the study, it was, of course, as you mentioned, a very well conducted study. And I'm sure that Dr. Sengupta will let us know statistically how it stands. But in terms of clinically, it kind of re-emphasizes, and that's what it's going to do, because you take a large group of experts who manage these diseases, and then the preferred practice, it's kind of like a preferred practice pattern of how they manage these diseases. So the important findings you've already highlighted. Whenever we have a patient who comes with unilateral uveitis, anterior uveitis, especially oftentimes you see granulomatous anterior uveitis, but it's not necessary, and with pigmented KP sometimes. And if you have high IOP, for most of us practicing uveitis, that is enough to diagnose the patient as having viral uveitis, sometimes viral ketouveitis. So in these cases, we start the patient on valacyclovir or acyclovir. One interesting point that was brought out in the study is that corneal sensation as well as raised IOP were top two adequate criteria, and sector iris atrophy for HSU were criteria enough to diagnose. I must say that for me, corneal sensation, being a cornea specialist, I do test in all patients. But in the cohort of patients that I have seen, if they have only anterior uveitis in my clinical practice, I have not seen that the sensation was equivocally decreased in the affected eye. So I wouldn't, in my practice, I wouldn't use this criteria, meaning even if the sensation is normal, I would still think of viral. If it's abnormal, then obviously it just helps us detect all the more. So for me, the top three criteria remain unilateral uveitis, maybe granulomatous with high pressure, and anterior segment is affected. So I would treat the patient with antibiotics.
Can I go in?
Yeah, Dr. Anirudh.
Yes, indeed.
Thank you so much, the leadership of MOS, BOA. Thank you so much for having me here. It's really honor and pleasure. And I think Dr. Somashila ma'am has already given us a very good gist. A wonderful presentation, by the way. I think you've very concisely given us all the key points from the article. Before I begin, I must say that a disclosure, which is I was a co-author, so my job is not really to praise the paper here, but I will bring out some criticism of the paper, and hopefully we will learn something from the criticism. So number one is that these type of manuscripts, which are consensus-based guidelines, do not help us in practically treating a single patient in your clinic. This is not the real aim of building a consensus guideline. So when you have a patient, you have several factors which are not considered in this consensus guideline, which include, for example, corneal sensations. Like Madam pointed out, do not test corneal sensations routinely in all my patients. I find it to be of a very good negative predictive value. So if the corneal sensations are absent, yes, it points towards viral, but it may not be, and we don't really know the sensitivity of this particular test. Also, what is not mentioned elaborately, and it's possibly not one cannot do it in such a consensus manuscript, is looking at each individual blood test serum markers separately and their relevance. And I think once you have the lab capabilities to definitely do a PCR, there is no doubt that PCR is the gold standard. And as much as you can do, you should try to do PCR. But lab tests are something which are corroboratory. So I think this is something which may not be highlighted in details in this particular paper. Of course, when you have a patient in front of you, you must distinguish three entities, which is the varicella zoster, herpes, and cytomegalovirus. And the fourth entity which must be ruled out is Fuchs, heterochromic uveitis. These subtle points may not be addressed in this consensus guideline. So when you have a patient in front of you, you must consider three phenotypes. One, which is acute granulomatous uveitis, which is typical viral presentation, which is unilateral, high pressure, maybe poor corneal sensations, iris features, and you may or may not have vitritis. Especially if it is varicella, you'll have vitritis, you'll have posterior synechiae. You may or may not have posterior segment lesions. So, and typically unilateral. So, this is the acute granulomatous presentation. I think the consensus guideline really focused on this particular presentation. But you also have the other presentation, which is the Poschner-Schlossman syndrome. And Poschner-Schlossman is characterized by the white eye with high pressure. And the feature there is trabeculitis. You may not necessarily have the corneal sensations. And in these patients, you must basically treat bioclinical suspicion. And of course, if you have PCRs or if you have even biopsies of the meshwork, if possible. The third phenotype is Fuchs heterochromic uveitis. And I think Fuchs must be the first thing that you rule out in all your patients. We have patients when I was in PGI, I had patients who had Fuchs and had positive serum markers for varicella as well as herpes. And I had 6 patients who were PCR positive from aqueous for cytomegalovirus. Now, if you look at Singaporean data, this Singapore data is kind of skewed, and the incidence of cytomegalovirus related Fuchs uveitis is quite common, whereas the American data says that rubella is associated with Fuchs. So this is one area which is possibly not really addressed in this consensus guideline. I think one more thing that we must consider when we are looking at consensus is that these definitions are very precise. There is no gray area. So when you have a patient in front of you,
It's time for bed.
You may be confused about corneal sensations, for example, yes or no, or absent or present. Now, in the consensus guideline, you don't have a grade or you don't have a grading scale. And probably Dr. Sabyasachi might elaborate more on the Likert scale. And you have certain Delphis which are run by Likert scale. That means you have a grading. And here we don't have a grading. We have yes or no. And so this is another thing which can be a problem in these consensus guidelines. Overall, I think the consensus guideline is very useful in telling us some things that the experts believe. For example, I have stopped using acyclovir. I use val acyclovir in all my patients. I have stopped doing quantitative PCR. I think that's very excessive. It's not practical to poke the needle in the patient's eye every visit in the follow-up. I have stopped, for example, using topical, agents without cover of antiviral in suspected cases. I think this is something which is very firmly coming out from the consensus guideline. One thing which is missing from the consensus guideline again is the use of topical antiviral gel. And I think there was a mention in the presentation about the HEADS study. And I think topical antiviral gel does have a role, especially if it's a recurrence of disease with corneal involvement or if it's a low grade inflammation. If you read the review article by Soonfek Chi, I think Soonfek Chi from Singapore, she's definitely an authority in this. And she does recommend the use of topical antiviral gel. I do use topical antiviral gel often in my patients. It does have anterior chamber penetrance. So I think this is a very good add-on agent. especially in corneal involvement and in mild recurrences. Beyond this, I think the manuscript has been very inclusive. It has included several experts from around the world. It has a good methodology. Delphi is now commonly being used. And I leave it to, probably Dr. Sabyasachi sir to tell us more about how these guidelines work and how these statistics work. That's all from my side. I'm happy to answer any more questions. Thank you once again.
I had two counters for Anirudh, if I can, or I can wait for my
No,
chance.
no, you can. You can.
So,
Somashila.
so Anirudh, just like how you stopped using aceclidine and use only valaciclovir, for us, financial constraints do come into play. And as cornea specialists, we've been using aceclidine for donkey's years and parola debris. So we have a lot of confidence in that drug. So even till date, if I have a patient who's financially constrained, I use aceclidine. And if the patient has better finances, I use valaciclovir. And if you, so it also seems in the discussion when you go through the article that Pallavi presented, that the authors themselves seem to have a bias towards valaciclovir. The reason I say that is because they brought out literature talking about aceclidine resistance. And they also admit that valaciclovir was used not because of any scientific evidence on its efficacy over aceclidine, but because of the dosage and convenience of use of that. So I would not disregard aceclidine. I think it's a great drug. It's just that valaciclovir dosage and the bioavailability is better. But our patients here, for the patient population here, we cannot completely. The second counter I had was for the gel. So in Soonfig cheese, if I'm not mistaken, I think they use the 2% gel of valganciclovir, but the one that we have here is 0.15%. So although I do use it exactly as you said for small, less intense recurrences where the patient has received adequate treatment, but the original has 2% versus 0.15. So efficacy wise, it may not be the same. I don't know.
If I may. So I do agree that there is a bias from the authors for sure. This is the problem with these consensus guidelines, that they are biased and they're all from developed countries. There is no African representation as mentioned, and so this does create a problem. The problem with aciclovir is, of course, it's financially very much viable. The problem comes in resistances, and I think that, and compliance. So if you have a patient and you have a choice of valaciclovir or aciclovir, then I would probably use valaciclovir. So I think I'll rephrase and I stand corrected. Second point, yes, I think 0.15% ganciclovir is, we do have 2% here, but I think it's very heavy for the cornea. I think corneal toxicity or probably just causes dryness, stinging. So I do stick to 0.15%. In very mild recurrences, it works fine. It's a good add-on agent, I think. So I have some patients, and probably some general practitioners may have patients who are extremely mild and they just need that hair on the camel's back, which is that 0.15% gel and maybe some antihypertensive topical timolol or Cozopt, and they are completely fine without any recurrences. So I think for some of these patients we can have this gel formulation.
Great point, Sunil. Thank you.
Thank you both the panelists for your comments. We'll come back to you. I think since this is a slightly different kind of study from the ones that we are conducting normally, I request Dr. Sunny Sen Gupta sir first to speak about the biostatistics, the Delphi part, and then we'll go on to the question and answer with the panelists. Sen Gupta sir, if you may.
Yeah, thanks, Zain, and very good evening, everyone. So,
I want to interrupt just 1 minute. I want to ask one question: whether this anti-uveitis is antigen based or it's a directly virus causing the disease. Just a very basic question. I want to just know the answer.
It's a direct viral invasion, sir. It's direct infection. The DNA of the virus can be isolated from the anterior chamber.
Okay. Thank you so much.
Gupta sir.
yeah. So, I think I'll quickly summarize the sort of important points that have already been discussed. So we all know and read about viral retinitis, right? We know what is acute retinal necrosis, what is POR and some of these other retinal manifestations. But viral anti-uveitis is not easily diagnosed. I mean, all of you in the audience and listening, how many viral anterior uveitis have you diagnosed in your practices over the last, say, 4 or 5 years? And because it comes in front of our eyes, but then we don't know how to diagnose it, right? So I think this is a very important paper which tells us how we can go about at least considering that this might be a virus. And so the in one sentence, sort of the diagnostic criteria is that when you see a unilateral hypertensive uveitis with sectoral iris atrophy and iridoplegia, so that's like a one liner if you want to look at the diagnostics. So it's unilateral most of the times. uh, then it's hypertensive. That is, IOP is regularly more than 40, and you will see sectoral iris atrophy and something called iridoplegia, where sort of the pupil is about 5 millimeters, not reacting well to light, and you might say that it is because of the raised pressure and because of the anterior segment reaction. But then most significant anterior uveitis will have smaller pupils or posterior synechiae, and that is significantly absent in this condition. So the pupil is relatively larger. The iris is sort of semi-paralyzed, you can call it that. So they call it iridoplegia. So this is what when you look at this, you definitely think about viral anterior-uveitis. The second thing that they talked about was the diagnostics overall. So, if you're ordering a PCR on an aqueous tap, definitely order a qualitative multiplex PCR. But then, a lot of people didn't find usefulness in this because they just said that it is not available with us, right? So, if at all you're ordering a PCR, do a qualitative multiplex PCR. Quantitative results are also important as they show viral load, but then it's impractical to do that all the time. And then the third thing the major thing they talk about is treatment. So there is a topical high dose steroids with oral valacyclovir is what they said, and the time point or the treatment endpoint that all experts agreed was on resolution inflammation, and more than that, there was more consensus on normalization of intraocular pressure. Right, so that is one of the more important endpoints, because we know that if pressure remains 40-50 for prolonged periods of time, it can cause a lot of damage. So this is overall in quick summary of the points that were given. Uh, then points on how a consensus is created. So consensus really means that the need for a consensus really shows that treatment patterns are disparate, including whatever is being used. So we, like I said, it's very difficult for us to actually sit in clinics and diagnose a viral anterior uveitis vis-a-vis a viral corneal ulcer or herpetic corneal. Different manifestations are well known, but anterior uveitis without corneal involvement is not well known, right? So there was a need for a consensus in this. The 2 or 3 methods for developing consensus is, of course, this Delphi system. Then there are things like nominal group techniques, where you have like a core group and they go over many different ways of looking at the disease. And sometimes people have an entire conference looking at consensus development. So a lot of these, like the NHS in the UK, have consensus development conferences where these experts are there. But then Delphi is the most common way of looking at it. So the couple of points or problems rather with Delphi is that they are biased sometimes, especially dependent on who is developing these questionnaires. Sometimes the order in which the questions are given can influence the people and their choices. Sometimes there are contextual clues or focus of a particular question, and then so uh, this I don't think there is a link to the actual questionnaire and the way these 21 questions were given, and in the order in which they were given. So that is something which the authors perhaps could have given us a link and said, this is the Google form, or this is what was actually done. So then that might actually have helped us. Uh, but overall, the Delphi is by far the most common way of developing questionnaire, developing a consensus. If you read a consensus statement which is not done using any of the commonly used consensus development methods, don't believe it, because then it's just what you think and what I think, and there will be no disagreement in the end, right? So that's a little bit about consensus development. When you look at the analysis, the same authors, that is Dr. Vishali and Rupesh Agarwal, and they have done studies on ocular tuberculosis as well. And Anirudh was also a part of the study on consensus development for ocular tuberculosis, where they actually gave the median and interquartile range for each of the questions, and then actually gave us the conclusions. But here they don't give us any, they just talk about percentages. They don't give us any medians and interquartile ranges in the responses. Right. So they just give us, say 16% agreed or 30% agreed or 70% agreed. But then, if the outcome is actually based on median with interquartile range, then we need to see those values, right? For example, when you say we use corneal sensations, we don't know how many percent people agreed to that statement, because that is not there in the results at all. So then it's very difficult to then realize exactly, so we know the qualitative outcome of the paper, but the quantitative outcome is not given. So then I think that is a little bit of a lacuna in where the results are presented. Whereas the ocular tuberculosis study is called the COT study, and they have multiple papers on that. I think that is a much better written manuscript in terms of how the results were presented. Here, that has not been presented. So, I think it's a great start in the way we look at viral anterior uveitis. But then there is a little bit of a bias in terms of how the study questionnaire was given, how the data was presented to the experts, how rounds were carried out, and finally how the outcomes have been, sort of interpreted in terms, especially in terms of the corneal sensation being used. But then there is no doubt that if it's a unilateral anterior, uveitis which is hypertensive with sectoral iris atrophy and iridoplegia, you should think about viral anterior uveitis as the first causative agent. So these are the points I thought I'll discuss.
Thank you, Sengupta sir. I request Dr. Sumita, to ask some questions to the panelists.
Somshila ma'am, I want to ask you, sometimes there is a particular situation where we can confuse the attack of ACG with uveitis, this anterior uveitis, because like here also we said there is iridoplegia. So sometimes instead of pupil being constricted, which is a typical sign of uveitis, pupil is dilated. There is corneal edema. There is secondary raised intraocular pressure. So in such cases, then how do we go about?
So if you mean an attack of angle closure. Yeah, so that ideally you would expect, you can see the other eye for close. So the other eye definitely should have narrow angles. That would be the tip of the telltale sign. And in these cases where we're describing, even though there may be some corneal edema, but you would expect to see chaotic precipitates. The corneal edema, you may not be able to grade the cells and flare, may see. It might obscure your view, but sometimes you can see some chaotic precipitates easily. And ultimately, unilateral inflammatory raised pressure with the other eye having a deep AC, then I would not suspect acute congestive or narrow angle glaucoma or narrow angle attack.
But we can have uveitis with the patient who has pre-existing, small eyes, hypermetropic eyes. So with the fellow eye being having an occludable angle.
Right.
And we do get to see cells and flare even in a case of ACG.
So it's like a double hit. So the patient already has narrow angles and is the tendency to developing angle closure. And on top of that, the patient has inflammation. So first we have to settle the inflammation and then try to see how best we can manage the attack of angle closure, whether we can do, I mean, what you're saying is, in other words, we'll have to consider doing a gag laser PI. One more situation where sort of the other way around, where you'll have very shallow angles, may even be bilateral. So you can have a patient presenting with bilateral, what looks like very shallow AC, even the peripheral iris is going forward, and it looks like acute angle closure in both eyes. But if you look at carefully, you'll see some signs of inflammation. So there are differential diagnoses. For example, BK syndrome can present like this. Uveal effusion syndrome can present like this. So it's a great question. So we have three entities. One is that it's pure uveitis mimicking angle closure, and it could be unilateral. Second is that the patient has propensity to go into a pupillary block due to narrow angles, gets uveitis. And the third is that the entity of uveitis, like BK syndrome and so on, mimics angle closure glaucoma. So these are the three things that need to be differentiated.
So maybe here we can really go ahead with the PCR testing. Should we, if we have such a doubt?
No, so I would not. So Anirudh is at the beautiful picture you saw where Anirudh, his backdrop is actually Cleveland Clinic, and it's a beautiful place. He has access to everything. So if I'm sitting at a tertiary eye care institute like LV Prasad Eye Institute or any other PGI and so on, so you have access to aqueous testing. But if you're maybe a DY Patil, you have the two. But if you're you're in private ophthalmologist seeing the patient, and so by the time you collect the fluid meticulously, send it for testing and so on, so the chances of false positivity would be very high. You might miss the virus in the sample that you collect. So I would not attribute that much importance to aqueous testing for diagnosis. It's more of a clinical diagnosis according to me.
So then in such states, can we start empirically acyclovir? Can we give a...
So valacyclovir or acyclovir are extremely safe drugs, at least in short term. And there are a few lab tests that you can do to make sure that the patient doesn't have some renal compromise. And you can definitely give a therapeutic trial. The only time where I really want to do aqueous AC tap is when I'm suspecting CMV, or I've started the patient on antivirals and the patient is not improving, comes back with a recurrence. So there I want to do an AC tap because this patient could actually be harboring a CMV infection rather than HSV or VZV. So 2 out of 3 are likely to be right if you start acyclovir or valacyclovir.
So
Thank you, ma'am.
I just wanted to know if you could elaborate on PCR. How do you transport so for the general people who want to still send, so what should be the quantity that you should be sending and how?
So this will be in the context of you have to send the sample to another external lab.
Yes.
So there is, since I recently moved here, so we set up a way of sending the sample to an external lab. And what we need to do is collecting the sample. So we have to collect as much sample as we can. But believe me, beyond 0.2 ml, you can't get more sample from the aqueous. And you need to be very careful. So I typically just use topical anesthesia and of course, drape the patient, just like take all aseptic precautions. And under topical anesthesia, I typically tend to use a 27 gauge. I could use a 30 gauge also, but for me, I like to use a 27 gauge needle and just enter into the anterior chamber, taking a lot of care that if the patient is faking, that you don't directly traumatize the lens. Once you're inside the AC, very slowly, this is really slow, keep withdrawing fluid. So literally you withdraw, wait for the AC to fill up again, withdraw some more. And that is the only way in which you can get a sample of more than 0.1 ml. If you just go in and withdraw fluid, you won't get more than 0.1 and AC will just collapse. And then the endothelial cells will touch the lens or something like that. So you have to be very careful. And if you're able to obtain that, so you can gently withdraw the needle. And now be very careful you don't lose your sample. So what I do is I bend that needle and I apply some kind of tape so the hub will not accidentally get pushed against the needle. And we ask a particular lab who comes and collects a sample in cold storage. So you put that sample in cold storage and they process the sample the same day. So they can either do multiplex PCR or if you ask them exactly what viruses you want tested. So that is very rapid. They can finish it the same day and within 4 to 6 hours, you can have your report.
Thank you. Yeah, any further questions, Zain?
Yeah. So just two questions for Dr. Anirudh. One is with respect to the points that Sen Gupta sir pointed out, since you were part of this trial, the quantitative assessment, in terms of interquartile range has not been presented and only qualitatively. So any particular reason why this could have been done, or this was just a limitation of the study?
I think that did not happen because this was, like I said, not a graded questionnaire. The questionnaire had only yes, no. It had different scenarios. So it had, unlike the collaborative ocular TB, here the audience, the person who responded were presented scenarios. So they had to kind of say yes, no. So there was no scope to give the interquartile range for each individual question. And honestly, the way it was designed, the questionnaire, there was an inherent bias, like Dr. Somashila ma'am mentioned. towards a certain conclusion in a way, so to speak. So we did not have interquartile range. I think the interquartile range also would lead to more confusion in this regard, because unlike the collaborative ocular TB where you had three variables, so you had quantiferon, you had chest X-ray, and you had Montu test, so immunological and radiological. So there were lots of variables there. Here, it's a very specific case scenario. You have a unilateral disease, high pressure, corneal sensation. So this was not a manuscript where interquartile ranges could possibly be applied. I think things could have been done better, but maybe we could have used a different scale, maybe a Likert scale or something of that sort. Now there are different types of Delphi which are being used. So we have for example, visual Delphi or a case-based Delphi. So I think there are lots of things coming up in these to address these limitations, maybe in the future. For example, the Singapore meeting, which is Inflammatio in November, is going to be based on visual Delphi for white dot syndrome. So you're all invited for that meeting. That's an IUSG meeting on white dot syndrome.
Dr. Anirudh, what would be
Yes.
your end point of stopping the treatment? Here in this article also there was a lot of different points that they had mentioned, that either the inflammation comes down or the intraocular pressure comes down, or finally the corneal edema. Some say corneal edema is resolved.
Yeah.
So what would you consider as the end point of stopping your topical steroids?
Topical steroids. So oral I would stop. I would use for 6 weeks, and
6
then
weeks.
maybe use only prophylactic dose. Most patients, they even stop prophylactic dose, unfortunately. Topical steroids, I would like to continue as much, even if the patient is using once a day or alternate day, one drop. Sometimes I have patients who are using 2 times a week. So as much as possible, as long as possible. If it is not prednisolone, I ask them to use Lotimax, for example, lotiprednol or fluorometholone, and that is enough. So I ask them to use as much as possible for a year, 2 years, or until they get tired of me and stop coming.
Okay, in spite
Ultimately,
there
they
is
will
no
get
signs.
tired.
Yeah,
This is at first presentation. This is at first presentation.
No, first presentation you start acutely, right? You start 4 or 5 times or 1 hourly or whatever, and then you taper it off. But then I don't stop
You don't stop.
corticosteroids very soon. I
Okay.
take my time to stop it.
Okay.
I just wanted to add one little thing there, based on the previous question. I am yet to see a patient of viral anterior uveitis with angle closure. For some reason, most of the times with viral anterior, they develop deepening of the anterior chamber. And I think that happens because of ciliary body swelling. And most of these patients could have synechiae or even fibrin in the anterior chamber. And if you look at these patients, they develop secondary open angle glaucoma. That's usually the mechanism of glaucoma. And really, if you treat them also, you will realize that hardly any of them have steroid response. If their pressure starts going high in the follow-up, it's a recurrence usually of the viral uveitis. I'm very few, maybe rare cases of steroid responsiveness. I don't know why this is happening, but in general, it's possibly to do with the angle configuration.
So my theory here, I completely agree with Anirudh. My theory is that apart the initial trabeculitis and then they have secondary angle closure, kind of a glaucoma, rather than steroid response as well. So I would look at other mechanisms. And in addition to Anirudh, you mentioned fibrin. They also, especially HSV, also has a sort of a hemorrhagic hypopion sometimes and a lot of pigmentation.
Yes.
That's one of the differences.
Amsler's sign.
Yeah. And well, yeah, kind of. And also one question that Zain had asked about the duration. So duration of prophylaxis as well as duration of corticosteroids. So I completely agree with Anirudh. Very slow taper, and then I swap the potent steroid to sort of a low dose. So try to find the least possible dose with which the patient is symptom free and the pressures are stable and so on. And also the oral medication, after a while, you're forced to switch it off. We can't keep it forever and ever. So maybe 6 months is a good trial. It depends on the stakes. Like you have a one-eyed patient, or sometimes they have scarring which was already central. So it depends on how high the stakes are. So that could also modify. If it was a mildest, like Anirudh mentioned earlier, sometimes you have patients with very mild disease. Give them the minimum amount of treatment and they're good. So it depends on the patient that you see and the pattern for that patient.
Just one thing I'd like to add. I have some patients who use it PRN. They use topical steroids PRN, and I'm kind of okay with it. I tell them don't use it more than 2 times a day, fluoromethalone. And I also have some patients who go on Amazon and they buy a tono pen and they measure the intraocular pressure at home. So you have all kinds of patients now. So I think you have to kind of communicate.
So, just since we are coming to the end of it, just as a take-home point, for a general ophthalmologist sitting in the OPD or private ophthalmologist, what we see a patient with unilateral uveitis, anterior uveitis with raised IOP. At this point, do we treat this as a viral anterior uveitis and start the protocols that are recommended, without going ahead and doing your aqueous sampling and things like that? I mean, there are the signs like, sectorial iris atrophy and iridoplasia and all, but I'm not sure whether those are seen in all the patients. But just a raised IOP with a uveitis, open angle. So should we treat it as a viral and start the treatment?
So
Maybe I can.
yeah, sure.
Go ahead.
Go ahead, Anil.
I just want to clarify on this point that you raised there. I think this is really important. If you have a patient in the clinic with an acute presentation, there is no synesthesia whatsoever. There is a acute uveitis. This is possibly the first episode. Please be careful in starting antiviral. Don't be in a hurry to start antiviral. It may not be viral. Okay, it could be idiopathic anterior uveitis, which is very common. And the problem is when you give antiviral, it distorts the picture. It makes it very difficult to establish the diagnosis. So I think you should be careful. But if it's a chronic presentation with synesthesia, you have granulomatous KP, very typical presentation. Yes, please go ahead, start antiviral without getting PCR and other things. If it's a gray area, if you have a situation where you are confused, there is no problem in starting topical steroids with atropine or tropicamide while you're waiting for your corroborative lab tests, unless there is a corneal involvement. You're not doing a crime by starting topical steroids and atropine alone without the cover of antiviral if there is no corneal involvement. But if you have a typical case, go ahead and start.
So, Dr. Agarwal, can you depend on the antibodies in the blood or no?
Yes, I mean, they are corroborative. So I think if they will support your diagnosis, they will not be able to confirm your diagnosis. They will support it only. It is rare to get it in a negative. Like, for example, if your immunoglobulin markers are negative, then it's not likely to be viral.
Can I add a point here?
Yes.
If you allow me, yeah. So I think a couple of points. One is that acute angle closure is not at all a differential here, because the picture is really different. Acute angle closure will have angles absolutely closed, as we know all of those, right? And the lens is almost at the back of the cornea, and here it is far deeper. So then it is not really a differential diagnosis. Don't go poking into the eye. If you suspect angle closure, don't go poking into the eye, because we know anything can happen. You can touch the lens, you can have iris prolapse and all of those things. Second thing is, if it's an acute presentation and the IOP is high, I generally, what I do is I look for an immunocompromised status and I ask them, whether they're on any immunosuppressive medications or, sometimes. So I've had patients who have had Ozurdex, and after the third Ozurdex, actually they have developed this kind of picture. And they have responded very well to valacyclovir and all of those, and so Ozurdex also sometimes makes, Ozurdex is known to cause CMV retinitis, and I have seen Ozurdex, post Ozurdex viral anti-uveitis. People are on all sorts of immunosuppressive medications for like SLE and lupus nephritis and all of those. So I've had patients who have that kind of a history. So if there is a history of immunosuppression, systemic immunosuppression, and you see this picture, usually they are slightly older people. They won't be in their mid-20s, early 30s. So, but that systemic history, I think, is very important, and I think all of us should look for that history. If there is a significant systemic history of immunosuppression, then I would go ahead and treat with oral valcyclovir right at the first picture.
Yes, Somshila, your comments.
I just wanted to say, answer to Zain's question that we must rule out the differential diagnosis. You have a patient coming in with what looks like acute anterior uveitis with raised pressure, with or without the other findings. So to ensure that you're not missing anything in the back. So as kind of agree with Dr. Sen Gupta that you have CMV retinitis in the immunocompromised, but most of the patients with, I don't know the percentage, but with viral anterior uveitis, they're immunocompetent. And you do have co-associations like diabetic patients, elderly patients, also history of using anti-glaucoma medication. You know that these are common reasons why they can develop viral infections. But on the whole, what we have seen in the cohort, we haven't yet published, but what we have studied is that they seem to be immunocompetent when it's anterior uveitis. But so somebody like me and every patient that comes in with a unilateral anterior uveitis and raised pressure, I tend to treat as viral, but that's a tendency I have to curb because of two examples. One is that one patient turned out to be toxoplasma retinochoroiditis, where you can have raised pressure and you can have what looks like granulomatous inflammation. And unless you thoroughly examine the posterior segment, you might miss it. And the second patient, which was quite a way of the diagnosis, actually turned out to have endogenous endophthalmitis, bacterial endophthalmitis. And initially the pressures were 60 and it was cornea was so steamy you couldn't really see anything in the back. And so we started the patient on antiviral and of course IOP lowering agents, and the patient came in the next visit after 3 days. So we could see that there was some vitreous inflammation and some exudates. So luckily we could salvage. So never be wedded to a diagnosis. You must have a very robust reason to suspect viral before we start treatment.
So,
Like in these patients, if we think of a cataract surgery now with the
Right.
past history of uveitis, then what is your regime? Or do you start any prophylaxis before that?
Yes, I always do. Most of us, I'm sure Parul will agree, as we plan to do, say, cataract surgery for viral keratitis, or if we do corneal surgery, any surgical intervention, we tend to resume the antivirals in case the patient is off it. More because they might end up with dendritic keratitis rather than another recurrence of viral antiviral. I don't know why this is, but we've had cases like that.
So you start with oral again.
Correct, yeah. Start with oral at least 2 weeks before I plan my surgery, 2 3 weeks, if I can.
yeah,
So it was a great discussion, and we have almost run over time. So concluding remarks, if you want to give Dr. Somashila the takeaway points which you want to give our audience today.
Yeah, I think that there are two things. One is about the study and how to interpret the study that came out very well with Anirudh's comments and with Dr. Sen Gupta's comments. Priyanka presented Delphi kind of a survey, which is a way to report to, it's something we all of us can also think about doing. And the second part is, of course, the subject itself, which is about viral anterior uveitis. I think Priyanka's last slide summarized patients, the typical pattern and the treatment. So I think that you just see the last part of a presentation, which is there in the article, that pretty much gives you an algorithm. So just memorize that algorithm and you'll be good.
Dr. Anirudh, your concluding remarks?
I feel that this is an important area. This is an area where we are still learning. So I think each case must be handled very carefully. I think this study adds value to the literature and improves, our knowledge, especially the signs and features of viral anterior uveitis. Thank you for presenting.
Yeah, I just ask our MOS secretary, Dr. Atul Khadane, to give the Thanksgiving. Dr. Atul.
Sir, you are on
Unmute
mute.
yourself. Unmute yourself. Dr. Atul, you unmute yourself.
I'm very sorry. sorry.
Yeah,
I just forgot to unmute. At the outset, I like to thank BOA first for including MOS in such a beautiful, nice activity. And I must say that this is a very wonderful concept where we all collectively keep ourselves on the top of what is going latest in the fields. I know that I had subscribed journals way back, and now they must be somewhere lying somewhere coffee table. But such activities will initiate our MOS members, and you people, BOA members, are doing this journal club. But with including MOS, maybe our members will we'll have that again. There to take out bring the journals out and have a look after them. Thank you so much, Dr. Somshila Madam and Dr. Aniruddha Agrawal sir, for taking out the valuable time and enlightening us about the various aspects of the UVATIC this case presentation. Thank you so much, the presenter, Dr. Priyanka ma'am. Thank you so much, our moderator, Dr. Parul madam, and the Zain. And as thank yous to you also, Vaishal Kenya sir, and our the president, my MOS president, Dr. Santosh Agrawal. So hope we in the next BOA again with this journal activity. I request all my MOS members also please attend. This is a very nice activity and you really learn a lot. You get an analysis. Thank you, Dr. Sabbachi. You give a different way to look at the journal, whatever the topic you are reading, how to take the things in a different angle also. Thank you, everyone. Thank you, sir.
And before I should thank Dr. Sumita Karandikar, madam, for
sorry, I forget.
Participating in the Journal Club meeting, and our team, our dynamic team of Dr. Parul Deshpande, Zain Khatib, and Dr. Neeraj Israni, and Dr. Sabyasachi, who always this team together makes a dynamic team to bring this Journal Club again and again bi-monthly. I thank Dr. Soma, Dr. Anirudh for sparing their valuable time and discussing this topic thoroughly. It was a valuable meeting today. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Bye.
Yeah.
Thank you. Good night, everybody.
Thank you. Good night.
Right.